Afternoon. Thank you, Jorgen. It's a pleasure to be here. I'm going to give you a view of low back pain causality from the other side of the ocean. And the first thing I have to say is I don't know what causes back pain. Okay? I really don't know what causes back pain. But I don't think anybody else does either. So I think I'm okay. Okay. But I've been working in research in low back pain for the past 25 years, believe it or not. And what I'd like to share with you today is, I guess, my view of the world, what I've learned, what trends I see in the literature, what trends I see in our own research. And I'd like to mix the review of the literature with some of our own work and try and paint you a picture of what I think it's all about. Okay. I was part of the National Academy of Sciences study that Hilke referred to that was published in 2001. This is a group of 19 MDs and PhDs in the U.S. who evaluated the work-relatedness of low back pain. Some of you may be familiar with that report. And so part of what I'm going to say comes from that. The other part mixes in with my own personal work. The focus is going to be a little bit different from what you've heard today. You've heard a lot about epidemiology, and I think we all know the epidemiology. The secret to understanding low back pain, or at least having a clue as to what it might be about, is the causality element. So that's what I'm going to focus on today. I'm going to talk about how biomechanics, how biochemistry, how work factors may lead us down that path to low back pain. Okay, so that's where I'm coming from, and I'm going to take a systems approach as opposed to a very focused approach. I'm going to back up to 35,000 feet and look at all the literature in mass. That's what I'm going to do. Okay, what started this whole thing? Rick Deo is an MD from the state of Washington, and he was quoted in Scientific American in 1998 about the time that this "we don't know what causes back pain" movement, or it's not related to back pain, really to work, really started. And here's his statement. He said, "The economy is increasingly post-industrial," as Hilke mentioned, "with less heavy labor, more automation, and more robotics, and medicine has consistently improved diagnostic imaging of the spine and developed new forms of surgical and non-surgical therapy. But work disability caused by back pain has steadily risen." Gunnar Anderson from Rush Hospital in Chicago made the statement that 75 to 85% of all people will experience some form of back pain during their lifetime. So the obvious question is, are back disorders really related to work, or are we all going to get them no matter what happens? I think that's the issue that we're talking about here. Okay. So what I'm going to do then is look at the evidence that's out there from a scientific standpoint and consider collectively, and not one study at a time, but I'm going to look at what we call the pattern of evidence. What you've heard today from almost all the speakers has been what we classified in the NRC committee as the preponderance of evidence. And what we mean by preponderance of evidence is are there so many studies that show one way or the other way that there is or is not some relationship to low back pain. But in the National Academy of Sciences, we decided to take a look at whether, if you lay all these studies out, do they fit together, and does one part of the study answer part of the question, another part of another study answer another part of the question, and can you put these together like a puzzle so you can get the big picture? That's what we're trying to do. Okay, so Jorgen's questions, and I've rearranged these a little bit to suit my own needs. And is there evidence that low back disorders are caused by work exposure? Okay, a couple things to talk about, and this has been covered, so I'm not going to go over this in great detail, but if back pain was not associated with work, one would expect to see the incident rates of work to be uniformly distributed amongst all occupational categories. Okay, fair assumption? Here's what it's like in the U.S. This is only 120 million people so represented in here. So what we'd expect to see over these groups are people in these different areas would all be about the average right here. And this is, and again, this is only U.S. workers. But what you see here is, here it is, people who do heavy work such as agriculture, forestry, and fishing having very high rates of low back disorder. Construction's up there, transportation and public utilities up there. And then on the other side, you see people who sit in offices, for example, finance, insurance, and real estate, having very low rates of low back disorders.
These are incidents, these are prevalence, right?
Yes.
Your question was, your assumption was that the incidents were...
Could I finish my talk, please?
As long as I know what to replace.
Okay. Now, has this changed over the years? Yes, it's changed. As a matter of fact, take a look at what was happening back in 1992, and here we are 2001. And what you see is, yes, as Hilke recognized earlier, and a lot of our speakers have talked about today, everything was going down. And it is here. But look at the relative change between these. Guess what this is down here? Again, the finance, insurance, and real estate, and everybody up here are in the more physically demanding jobs. So it's changing, but it's changing in a relative kind of way. Are these associated with risk factors? Yes, we see that here are prevalence per 1,000 currently employed workers. Here are the risk factors with these jobs. This is repeated reaching, bending, and twisting. This is strenuous work, and you can see they sort of go along with the trends you see there with who has the most back pain. Let's compare two of these. The blue are office workers, the red are miners, and this is, whoops, now what have I done? Okay, but here we're comparing miners and office workers, and basically what you see is it's really interacting with age. In the younger years, 20 to really 40, there's not much difference between the back pain rates of people in those age categories. However, as you get older, look at the separation in these things. It increases rather dramatically. Excuse me. Now for some of the more formal studies. Those are just a couple individual studies. And this is something that Hilke talked about earlier. The studies are pretty consistent. Here are the risk factors. Hagedorn in 99 looked at 31 studies. Bernard, this is the yellow book, the NIOSH yellow book, so-called, and looked at 42 studies. And they pretty much agreed on the same factors here. This happens to be the Bernard table, summary table, and you can see there's strong evidence for lifting, forceful movements, whole body vibration, evidence, a little more moderate evidence, but still positive evidence for postures and heavy work, and insufficient evidence for static work postures. And the stars here indicate Hagedorn, which basically identified the same risk factors as being significant. But if you look at the data, you see a trend. And the trend is the more subjective the measures, the lower the odds ratios. The more, let's call them sophisticated the exposure measures are, the better your odds ratios, which means that maybe just self-reports, maybe just how many hours a day do you spend doing this or that is not the right way to go about this. Maybe we need more specific and accurate metrics to really figure out what's going on. Hilke talked about the review by the National Academy of Sciences. This is again the attributable fraction, which is the proportion by which the rate of the outcome among the exposed would be reduced if the exposures were eliminated. And what we see here are the attributable fractions. Again, they're somewhere between a low of 11 and a high of 80% reduction in back pain if you weren't exposed to those factors. And again, I'd like to note that not all studies are positive. Most of them are positive, and if you look at the rate here, it's a pretty good rate, especially for things like heavy physical load. 8 positive studies, 0 negative studies, or null associations, but not all of them are positive. And I think this exposure assessment problem is one of the reasons that you don't see more positive studies. So anyways, the surveillance data, epidemiologic trends, and the literature reviews suggest that work can play a role in the occurrence of low back pain. We just don't know specifically what it is, but it can play a role. And the other trend we're seeing is the more specific the physical factor characterization, the better the relationship with low back pain. Question 2, is the notion of primary prevention feasible? I think we have to do it. You know, if you look at the what Hippocrates said is the function of protecting and developing health must rank even above that of restoring it when it is impaired. It makes no sense to me to deal with people when they're injured and not try and prevent the injuries to begin with. It's much more expensive to do it in a rehabilitation way. Let's talk about causality. One of the things that we found in the National Academy study was that risk is truly multidimensional. I think everybody here has been saying the same thing. It's truly multidimensional. You have social organizational factors, you have individual factors, you have physical factors, and the big key is how do these come together to cause risk? And here are some of the things that have been suggested in the literature as being related to low back pain. We developed a model in the report that says here's how we think people are injured. And it starts with a load-response relationship here. And this is really the essence of a lot of biomechanics, a lot of biomedical engineering. And basically it says people don't get hurt when they don't get some type of an experience, physical experience. Okay? And there's some kind of load response, and this causes some symptoms. People could adapt to it. They could suffer an impairment from this relationship. If it affects their work, it could be a disability. And a big problem with a lot of the research that's out there is just self-reports or looking at lost time. Sort of depends on what you do. I've got back pain, but I've never taken a sick day for it because it doesn't affect my job. But if I was lifting things all day long, it might. And these relationships are also influenced by certain factors. The physical work in the environment, organizational factors, social contexts, individual factors, factors the worker brings along with them to the job, genetics, things like that. And they all mix together to cause this pathway to injury or to illness. Now, what do we do? And now I'm going to talk about some of our own research here. My training is in biomechanics, and what we try and do in biomechanics is talk about how much is too much. How much exposure to a risk factor is too much exposure to a risk factor. We differ a lot from the people who do the epidemiologic studies that say, do you lift more than 10 pounds? I mean, to us, that doesn't mean anything. 10 pounds, even if I knew it was 12 pounds, that wouldn't mean anything. I got to know exactly where that is relative to the body. I have to know how it's accelerated. I need to know how the person's dealing with that load, how they respond to it. I need the big picture, okay? And that's what biomechanics does for you. It allows you to put this in some type of a quantitative measure that allows us to deal with it. You know, I put a sound meter here because we know too much sound is bad for us, right? Too loud, right? Things are too loud. What do? We use a meter to determine how much is too much. That's what we're trying to do with biomechanics. If you look at the studies, again, there have been a lot of field studies that have shown a lot of these factors are important, and these are biomechanical field studies exclusively. And basically what you see is there are multiple factors, and almost all of them that are showing up as positive effects. Now, the basic of biomechanics is here. This is the underlying logic. There are loads that occur on the spine. Damn. I think I'll just use the pointer. Thank you. Why don't you just give me a regular pointer? Great.
Try to press X.
12 times? Okay. All right. In biomechanics, we believe that with every exertion, there's some kind of rise and fall in the load of the spine. And this load could be anything. It could be compression, shear, torsion, whatever. And if that load that is imposed on the structure is below the tolerance level, what that structure could tolerate, then we're in a very nice situation and we have a safety margin. And as a matter of fact, when engineers design bridges, roads, buildings, things like that. This is how they build things. They try and make sure this margin is as large as it could be. They figure out what the critical load is and double or triple it. Now, you run into problems when the loading pattern or the load magnitude exceeds the tolerance, and then that's where you have a risk of injury. Now, what affects tolerance? What will drop that tolerance? Well, end plate fractures, disc ruptures, vertebral body damage, all these things are shown in the literature to cause damage. Do we know how much is too much? Yes. Here's a summary of the studies that show that these structures can exceed their tolerance limits with these types of factors shown here. And notice they're not all the same. Some react to compression and tension, some react to shear, some react to torsion, some react to dose response. But a lot of animal and cadaver studies have shown in each one of these are the seminal articles, that we could explain at least how damage occurs. Now, you might say damage is a pretty extreme measure. We want to intercede in this system much before you start to get damage, and I'd agree. And because if you wait for damage, it's late in the game. This is a study by Brinkman, and basically showed there's some type of a relationship here between the number of load cycles on the spine, the load range, and the probability of causing damage to the spine. And notice it's a typical load response. You could have a little bit of load at a lot of cycles and cause damage, or a high load at a few cycles and cause damage. Okay, it's truly a load response relationship. How does age fit into this? Well, one of the problems that we dealt with in the National Academy study is, how do you separate people who've worked from people who've never worked? We have no idea how to do that. Everybody works. Everybody works at some part of their life, so it's really hard to do these nice controlled, randomized control studies where these people aren't exposed to the work, those people are. It just is an impossible situation. And what we believe happens with age is, obviously, it goes down, and once you're exposed to cumulative trauma and you have this dose response, that lowers your tolerance even more, so it puts you more in the risky area, or more of a chance of being in that risky area. There are other ways you could lower your tolerance that aren't related to physical load. Like I said, physical load to the point where you tear apart vertebral end plates and things like that is pretty extreme. And if we're getting there, we've got a real serious problem. But a lot happens upstream. A lot happens before you get there. And if you look at the literature, what they're showing is pro-inflammatory agents. You know, in the spine, it's all about cytokines right now. That's what everybody's talking about. A cytokine is a pro-inflammatory agent that when you're exposed to some kind of a stress, interleukin-1 or interleukin-6 or TNF-alpha upregulates. And what that does is make you more sensitive to pain. It creates a firestorm of activity around the joints of the spine. And if you put a little bit of pressure on there, all of a sudden your response is going to go way up. Where if you were doing that thing before you had that kind of sensitivity, you wouldn't feel any pain. Ann Barr has done some of the seminal work in this area, and she's shown that this inflammation occurs in response to injury stimulus, and it affects both the vascular tissues as well as the musculoskeletal tissues, and it's a pretty elaborate response, but we know it's real, and you're seeing more and more research in this area all the time. I think this will be our new threshold, our new tolerance in the future. We're not going to wait till things break. We're going to hopefully intercede when we start to get these pro-inflammatory reactions. And just like with the physical destruction of the spine, the literature has identified when these things kick in, when you start to get responses that will lead to pain, and you can see the literature is very rich depending on what part of the body is affected. Also notice you really have to get pretty specific about what part of the body is going to be affected, what part of the spine is going to be affected if you're going to understand how this injury or illness occurs. The other thing that muddies up the waters is adaptation. Okay? This is a classic study shown by Vitamin and Chaffin. And basically, those who are exposed to moderate work have the least risk of injury. Those who are exposed to sedentary work don't do anything, have moderate levels of risk, and those who are exposed to heavy work have very high levels of risk. This goes right along with the idea that Hedge was talking about, which is, exercise is good for you. A certain amount of exercise. You've got to keep at least some level of physical fitness for optimal health. Now, let's talk about the assessment of the loads that are acting on these structures. And this is where it gets fun. Here's our typical view of the world. You do something on the outside, you lift, you push, you pull, you turn, whatever. It creates a load on the outside of the body that's usually reacted on by either gravity or some resistance. And you've got to respond with the internal forces in the body, which are the muscles and the musculoskeletal system, ligaments, things like that. That's the basics of biomechanics. And from that kind of relationship, we need to figure out exactly what these loads are. And we have to do it more than just in compression. For way too long, our ergonomic studies have only talked about compression. Okay? I think compression is a very small part of it. The spine could withstand a lot of compression, but it could withstand very little anterior and posterior shear or lateral shear. If you look at the limits here of tolerance, these are physical tolerance limits, you can see 34 to 6,400 newtons of compression can be withstood by a person, or only 1,000 newtons of shear in either direction can be withstood. So we're missing the boat a lot of times because we're just looking at the wrong dimension. Our models have evolved a lot over the year. They've gone from static models all the way to dynamic, biologically assisted models, which are the kind I love. And instead of just having one muscle that responds, now we have multiple muscles that are represented by vectors in the torso. And if you understand what these vectors are, and you understand where the insertions and origins of these vectors are in the torso, you could predict the compression and shear on the spine. And this is the way we do it. We use our back monitor, our lumbar motion monitor, to figure out how the muscles are moving. We use electrodes to figure out how the muscles are working. And we use a lot of mathematics basically to turn it into realistic studies. And here's an example of somebody lifting. Here's the kinematics. This is the position, velocity, and acceleration of the spine. The muscle activities. Here's a cross-section of the muscle activities. Here's the mechanical advantage of every one of those muscles relative to the spine. Notice it's not just the erector spinae muscle, it's all the muscles. And notice some become negative, others are positive, which means there's a lot of coactivity. The extensor muscles are fighting the abdominal muscles. They fight each other and increase the load. And here's what that means in terms of load on the spine. This is the tolerance where you begin to have problems. Down is increasing compression. And what I want you to note is, these lines that go across here show where the person is in the video. When this peaks down here, notice what's happening here, which is a peak in the acceleration. Right there, that matches up with that. Okay? It's not just compression. Motion is important. Positioning is important. Changes, accelerations are important. Nowadays, we've gotten a lot more sophisticated about it. And for example, here's, people are really doing a reasonable job of modifying risks for lifting, but they're trading off these risks a lot of times for pushing and pulling, as you just saw there. And let me show you how we evaluate that these days mathematically. Here, a guy's still using a lumbar motion monitor, still the vectors of force. We can measure the vectors of force in the hands. We can put this in a model and figure out exactly what the vector of force is on each individual vertebrae at each individual disc. And notice the way this changes throughout the motion. This is the same motion you just saw. It starts to the back, then goes to the side. You see moments coming around here that show how each one of those is twisting. We can get very sophisticated about this stuff. Then we can put that information into a finite element model. And notice the way these things are changing colors, which tells us exactly when these discs are going to exceed certain property levels, which may lead to either breakdown of the tissue or perhaps someday an upregulation of those cytokines we just talked about. Did I miss one here? No. Okay. Now, in this example, what you just saw, just a pulling activity, everybody typically has looked at the biomechanics at L5S1. And notice These are the spinal loads in terms of compression, which is in the red, and green, which is in shear. And notice that the compressions aren't great. They're less than 2,000 newtons. Shears are under 500, which isn't a problem. But look what happens when we go up the spine. Okay, you get to the point here around L2, L3, L1, L2, where these shears now bump up against those tolerance levels. So part of the reasons biomechanics has not shown where the problems are in the past is because we've been looking in the wrong place. Okay, we're looking at the base of the spine when it's a little bit up the lumbar spine where the problems are really occurring. What about non-physical factors? You know, the literature shows that there are some psychosocial factors that could influence risk. And as we said before, it's multidimensional. And now, instead of looking at our individual silos of physical factors and organizational factors and individual factors, now we're bringing them together and trying to see how these things might interact. One study we did a couple years ago was looked at psychosocial factors and how it impacts the spine. And this takes a little bit of explanation. We ran a study where we were very nice to our subjects. And the experimenters, my graduate students, were bringing a subject in to run one of those models we just showed you. They were doing some exertions. They're all wired up. They had a very precise couple of lifts they had to do, and this was called the unstressed condition. Why was it unstressed? We were nice to the guy. We were whistling. My graduate student was looking him in the eye. He was, he turned on the radio. He was making all types of nice gestures to the subject. And we basically did the experiment, and then I walked in the room. I'm the stressor, okay? And what I did is I started yelling at my graduate student. I said, Bob, I didn't tell you to do it this way. How many times do I have to tell you? We pretended to have an argument. And I took him out of the room, and we pretended to have another argument in the hall, and then he comes back in the room, turns off the radio, doesn't look the guy in the eye, doesn't talk to him anymore. All he says is, we got to do this over. Now, if you look at the predicted loads on the spine as a function of subjects, notice some subjects showed exactly the same loading, where other subjects showed huge responses. The red is the stress condition, the greenish blue is the low stress condition, and no stress condition. And notice, everybody's different. Why? Well, one of the things we did is try to figure out what was responsible for this. So one thing we were smart enough to do is we gave everybody a personality inventory. Okay? And what we found is that certain dimensions on the personality inventory, like introverts and extroverts, explain the differences. The extroverts couldn't care less. Okay? When I went in and yelled at the guys, they hardly had any response. But the introverts, look at that. They almost doubled their response to compression and shear. Same thing with sensors and intuitors. Intuitors drove them nuts. Sensors, they couldn't care. We also did similar studies looking at some of the work demands that have been mentioned in the literature, such as pacing and mental processing. For example, here the person has to lift the box and just put it anywhere. Here they have to lift the box and put it precisely within an area, and you see little metal strips here that tell us when he's not putting it there correctly. And look at the differences in the loads when you have mental processing involved, which is in the red, compared to the green, which has very low mental processing demands. Same thing with pacing. Why were these occurring? It was back to that coactivation. When people are stressed, when you're of a personality type that's stressed, or when you're asked to do mental demanding tasks, what you do is you tense up all the muscles in your torso and you increase the loads on the spine. Not everybody responds the same. Is the notion of primary prevention feasible? Let me show you just a couple quick summaries of some research we've done. This is a study where we followed people before they made ergonomic changes and after. And we used, basically, we looked at their incident rates that were reported over the years. For 3 years before any change, we waited for them to make a change. We also did what we call an LMM risk assessment. Some of you might be familiar with the lumbar motion monitor risk model that we've developed. We used that to see whether we could predict the change that was going to occur. Then we followed them 3 years after the change looked at the injury rates, looked at the LMM risk model after. Basically what we found from the injury rates is they fell into three categories. For a third of the subjects, you had the desired effect. It went from a high injury rate to a very low injury rate. For a third of the jobs, it went from a high injury rate to a moderate injury rate. And for a third of the job, it went from a high injury rate and pretty much stayed in the higher injury rate realm. What does this mean? It means 2/3 of the time, ergonomic interventions don't work. 2/3 of the time, ergonomic interventions don't work. Now, we didn't tell these people what to do. We just watched. We were like voyeurs. Okay, we just watched what they did. And the good news is we could have predicted through our models which ones would work and which didn't. Here's the same thing looking at our risk assessment model. And the ones that had no change, we predicted very little change. The ones where we predicted a big change, we saw a big drop in our risk model. And the ones that had moderate change had a moderate change. So when you read the literature about interventions, not all interventions are the same. You could do a lot of the wrong stuff out there. Okay? And what we are advocating is better exposure measures. So you only do what you need to do. And as a matter of fact, if you take a look at some of the interventions in the study, lift tables and lifting aids such as hoists and cranes were some of the best interventions. They had a positive effect. Some of them had a negative effect because they did the wrong thing. And some of them had basically no effect whatsoever. So you need to know how much is too much. What about outside the laboratory? Here's a study that we're in the process of publishing in the American Journal of Industrial Medicine. And what we were interested in is, do patient handling intervention devices affect injury rates in practice? And there's lots of epidemiology studies that have shown that these things aren't may or may not be effective. I think most of the literature says they're moderately effective at most. And so there's a lot of controversy about this. The state where I come from has what's called a BWC, or a Bureau of Workers' Compensation. And in this, they have a safety grants program where they will pay up to 80% of an intervention cost up to $40,000 in the state of Ohio. And a lot of people took advantage of this program for interventions related to patient handling. And what we did is we took a look at how that occurred. And basically, we looked at 129 different work units and 111 healthcare facilities. Here's the way they're distributed. And basically, these were in large cities as well as rural cities in Ohio. And let me just go on to the types of interventions. There were things to reduce bending, such as elevated bends, transfer devices. Boy, what an idiot I am. Such as zero lift devices, such as hoists for the patient, reduction of carrying. So this is a seat with a big slide on the side, so you could slide people over as opposed to having to lift them and drop them in a seat. And this shows the number or the percentage of the study that was involved with each one of these. And also notice multiple interventions were used by 29% of the units. And in a nutshell, and what we did is we followed them for an average of 445 days before the intervention and 629 days after the intervention. And here's the average change. So this is the rate change in the number of musculoskeletal disorders per employee hours worked before the intervention compared to after the intervention. And you notice, on average, there's somewhere around a 40% decrease. So they're only at somewhere around 60 to 57% of the injury rate after the intervention compared to before. And notice the multiple intervention is the one that was most effective.
You didn't have a zero control group?
I'll get to that. Now, the interesting thing is not everybody improved. Okay, these are the numbers that decreased their injury rates, and you can see overall it's about almost 2/3 of the groups did better, and about 30% actually increased the injury rate, and about 7% stayed about the same. How did the back compare to other parts of the body? Back experienced about, on average, a rate of about 66, so a drop of about 34% in injury rates. And did it change over time? Yes. Part of the methodology here was to look at what happened every 6 months. And you can see it went down to rates of about 0.2 after about 18 months. So pretty good results with the back on this large study. Now the issue of a control group. This is tough in the United States. We're not socialized. Everything's private. And it is very, very difficult to say, could we come in and look at your facility, and we're not going to do anything, we just want to go and measure it, and go to other people and say, well, we're going to investigate you while you have an intervention. Socialized countries, it's easy. In the U.S., it's really, really difficult. But what we do have are BLS data, Bureau of Labor Statistics data, for that industry over the same period of time. And that's what's shown in green, and you can see over that period of time there was a 17% drop in the injury rates, where with our groups, with the intervention, there was a 44% drop. So, moral of the story again is it can work, but not all the time. Okay, and my hypothesis is it only works if you're doing the right thing. How should a campaign focus? I'm running out of time here, so I would suggest you've got to pay attention to the multidimensional aspects of the job. And how do you do that? We found in the past by having a program that deals with management leadership, employee participation, analysis of the job and control, training, medical management, program evaluation, and documentation, put together in a system like this that I don't have time to explain. But basically, it is a system. Again, we look at things at the system level, and ergonomic interventions by themselves will not have a good effect. Put them together with things like education, put them together with management commitment, where'd it go? Right here. Put them together with, getting input from the workers, you can have a good effect. How can you prevent absence? A lot of people have talked about this. Let me just show you briefly. We did a couple studies where we had people with back pain lift and then people without back pain lift do the same exact things. What do we find? The people with back pain doing the same exact lifts from the same exact spots to the same exact spots had higher loads, both in terms of compression and shear. And this shows the same thing, and what it shows is some of the more difficult lifts. These shows where people were lifting from and to. And you can see lifting to the easy places, like right here, there are minimal differences. Lifting to the more difficult reaches, like from the floor out away from the body, there are really big differences in the amount of load in the body between the two groups. Why? Coactivation. Keeps on coming back to the coactivation of the muscles. This is, again, when those agonist and antagonist muscles fight each other, and what we see is back people guard. They freeze up. Okay, so any intervention program has to consider this, and when you're trying to get people back to work, you got to get them functioning more like normal people who aren't always guarding, because the guarding can lead to things like the myofascial pain and trigger points and things like that that we know could run into problems. Can you predict it? Just a little brief comment on some of our analysis techniques. Hilke talked about the need for more quantifiable measures of back pain. Questionnaires can only go so far. How do you feel about your back pain? We need good quantifiable measures, and one of the things that we found is our kinematic profiles do a pretty good job of pegging where a person's at in their disorder. What we have them do is wear a back monitor, and then they play a video game with their back. They got to stay between certain boundaries and bend as fast as they can. We compare it to our normative group, and then we could actually predict the load with pretty good accuracy. We get R squared somewhere around 0.7 or 0.8. So this is their kinematic deficit. 0 means you have more of a deficit than 1. 1 means you're normal. And this is the compression on the spine when you're lifting different loads. And notice how predictable these are. Okay, a person with a large deficit, let's say right here, looks like a person without a deficit lifting a whole lot more weight. Again, back to the co-contraction. That's why. We've even put guidelines together, and I know these are difficult to understand, but basically this shows the deficit in kinematics here, the load here, and these are asymmetries. So we could map these out for the body, and we'll do a little advertising for Ohio's website here. You can find the guidelines in the website for the Ohio Bureau of Workers' Compensation. This will be in the handouts that come with the lecture. And we've also done this trying to see what factors predict recurrent back injury once people return to work. This is a study we just finished. We're about to publish with 206 workers that were followed for a year. And basically what we found is it's a combination of job requirements, very subjective scales, as well as job requirements, as well as social support, as well as some of the clinical factors we talked about. And notice, in sensitivity and specificity, we could do reasonably well. We could get in the 70s. And this is for predicting people who report pain in a year. But notice the way this changes when we get more specific about the back injury measure. For example, a medical visit. Now the values change. It still has all those factors in there, but you see only one of the subjective measures and a lot more of the quantitative factors come in here, both in terms of the person's capacity, that's the clinical lumbar motion monitor, and these are the work factors. And then if we even get more stringent with lost time reported by the company, you can see it looks, basically our models get pretty good. They're pretty close to 80% in sensitivity and specificity. And we get all these factors coming in here. Again, the Million visual analog scale is subjective. This is the clinical kinematic test I told you about. These are demand capacity ratios, and this is a psychosocial factor. So we can, with proper quantification, do pretty good at identifying what the factors are. So overall, there is a relationship, in my opinion, between low back pain and work demands, but it's not simple. Okay? The more realistic and quantitative the analysis, the better one is able to identify the potential causal pathways. Risk is multidimensional, and nothing's going to work until we recognize the multidimensional nature of the risk and start dealing with all those factors. The thing they all have in common, according to the way I look at the world, is all these increased tissue load in some way. Psychosocial, prior injury, physical factors. I think I could explain all those through some type of a loading of the tissue, or I think in the future, when we know a lot more than we have today, I think you'll see it will relate back to that. Coactivity seems to be the key for a lot of these factors. And remember, tissue response is more than just physical tissue response. It's biochemical, and we're going more and more towards that dimension. Thank you.